Hi, everyone. Welcome to Perfusion Musings, the podcast from Envello Medical, where we're diving into the science of perfusion, oximetry, and the future of cardiovascular care. I'm Casey Boutwell, the CEO at Envello Medical.
And I'm Thibault Romango, Director of Research.
We're joined today by Dr. Tom Hanff. Tom is an assistant professor of medicine at the Division of Cardiovascular Medicine at the University of Utah, and also a great Jeopardy player at AHA Jeopardy, if anybody saw that this year.
HFSA Jeopardy, yep. So it's really nice to be here, Casey and Thibault. This is some conversations we've been having offline for years now, and so I'm excited to be able to bring this and share it with some folks that might be listening in.
Yeah, it's great to have you here. So, oftentimes on the podcast, we talk kind of about the experience of managing cardiogenic shock and a little bit less about the real detailed physiology of what's going wrong that's leading up to this. What's going wrong cellularly, what's going on at the microvascular level, not just how does pre-shock feel clinically, but what's causing the symptomology of pre-shock. And so I wanted Thibault, our Director of Research, to be on here to have these kinds of conversations in a more public forum because we talk about it on all of our calls together, and I think other people might find it interesting.
Yes, so I'll get started. So my first question really, I was thinking, what is it that you're looking for in terms of the physiology at the onset of shock? Are there like tools you use, any specifics that you're looking for?
Yeah, so shock is interesting, and let me start by saying cardiogenic shock is not just one thing. I give a talk to the fellows, and I emphasize to them the heterogeneity of the disease that we have at hand. And so you could start with some basic things that we've known for decades, right? Some patients can go into cardiogenic shock after they've had an acute myocardial infarction. We call that AMI cardiogenic shock. Some patients can have heart failure cardiogenic shock, where they have chronic heart failure and then they decompensate. Now you can decompensate in sort of a warm and wet profile, where you're simply congested, we need to diurese you. But even more severe than that, and potentially even distinct from that, is the acute on chronic heart failure cardiogenic shock phenotype. I'm sure we'll talk a lot about that today. And then I guess the third group, not to be forgotten, but sort of in between those two phenotypes, is the acute de novo heart failure cardiogenic shock, like the fulminant myocarditis patient, where they may not have that chronic adaptive or maladaptive phase that the heart failure patients have, but they have this acute onset, but they've also got different pathophysiology than the AMI post-AMI patient. So at the beginning of shock, I think it's worth noting that as a heart failure cardiologist, I probably have in my outpatient clinic patients who are in this ambulatory cardiogenic shock phenotype, right? What do I mean by that? They might have very little perfusion problem, because that really is some of the trigger that sends people into the hospital, but they live with a chronic low cardiac output. If we were to do a right heart cath in these patients, it's not uncommon that which there was a comedian we were watching on Friday night. He was talking about his daughter, and the doctor said it's not uncommon. So he said, "So you mean common?" Which I thought was a great little joke. But it's relatively frequent that we would do a right heart cath and find that many of our heart failure patients are living in a low output state, but something is a dividing line. Something demarcates that progression from chronic phase to acute phase in the heart failure patient. And we don't know what that is. Where there are some signs, there are some clues into what it is, like when we are having to back off our neurohormonal blocking medications, right? Because patients are becoming increasingly hypotensive and intolerant to it. Why is that happening? It's not always the case that the pump is simply failing more, that the heart is pumping less, because they're already in that low output state. So one of the things that I'm very interested in my own research and clinical practice is, what are these transition points? What's the pathophysiology that's changing in these patients? And of course, there's lots of things that I look at. I think the summary word would be perfusion. It is not enough for me to do a right heart cath and look at cardiac output, because that tells me, to borrow a phrase from one of my former mentors, the ballpark, but it doesn't tell us who's winning the game. Are we getting oxygenated blood down into the tissues where we need it to, which I think is the driver of a lot of the secondary pathophysiology that's then triggered, that we lose control of, that we have these patients on fire. So I'm trying to look for early markers of malperfusion, or potentially the second wave of that, and related to it, are folks that are losing compensatory vasoconstriction. And just, to tell you why, I think if we did right heart caths in the 1990s in our heart failure population, we had a lot of high SVR, but we've actually managed that state, that chronic heart failure state. GDMT has exploded. and we have many ways to keep patients stable. But this end stage, the stage D transitioning into shock patient, I think are no longer this classic phenotype of cardiogenic shock with a low output, high SVR. I actually think they start to lose that, and they get this sort of double whammy of low output and insufficient driving force that leads to tissue malperfusion. So I'm looking for all those things. That's a very long answer for what could have been maybe a couple bullet points, but that's where my head's at with cardiogenic shock these days.
No, but this is the kind of things that I'd like to maybe dive a little more into the physiology if you
Sure.
want. I mean, so essentially, so I know there's like endothelial damage that happens, that inflammatory response. Is that due to the chronic? So the fact that those patients are in this chronic state, so chronic, with the pump malfunction, but chronic, right? Like you said, they live with this disrupted macro vascular function. And that is what eventually is causing the microvascular dysfunction with this endothelial damage, all this inflammatory response. Can you talk a little bit more about this?
So it's very complicated. I want to answer yes, but I have to add on a lot of asterisks around this because, in the 1990s, and Milton Packer published his seminal paper, I think in 1992, giving birth to the neurohormonal hypothesis, really tying together a lot of physiology we'd uncovered. In the 1980s, you would never give a patient a beta blocker. You were crazy to do that. Why would you decrease their inotropy? Turns out that's exactly what you need to do. So we had a good decade and a half of the neurohormonal hypothesis of heart failure. And then in the early 2000s, we kept measuring elevated inflammatory markers in the periphery. And there was a lot of excitement that we were going to enter into the neurohormonal inflammatory wave of heart failure. And the problem with that is we consistently measure elevated pro-inflammatory cytokines in chronic heart failure, and it correlates with worsening NYHA class and worsening heart failure pathophysiology. The problem with the model is that every time, the handful of times we've tried to treat that pathophysiology by targeting those pro-inflammatory cytokines, for instance, with TNF alpha blockade, not only did we not help the patients, the treatment arm in some ways did worse. And so it does create, as relates to inflammation, is inflammation a driver, or is inflammation just a signal that the house is on fire, and that the inflammation is actually itself a response to some other pathophysiology? There are many mechanisms. The reason I want to say yes is there are many ways that we can look at inflammation and in animal models or in our imagination with clinical models explain a lot of the phenomenon we see. The SIRS response may be an element of that loss of compensatory vasoconstriction. Inflammation at the level of organs can lead to dysregulation of microvasculature blood flow, but we can't put the nail in the coffin and call it that yet, because we don't have a therapy that we can go and intervene and show, yes, in terms of the Cox postulates for what's proof of principle in medicine. We don't have that final piece that we can treat it and make it go away. And that leads to two questions. One is, do we just not have the right scalpel? We can't give necessarily a steroid or a TNF alpha inhibitor that's very upstream and potentially simply just markers and without causing harm or not doing benefit. But there might be a scalpel approach. It might be a particular cytokine that we haven't discovered yet or found applicable. IL-6 comes to mind, and we are looking at IL-6 blockade with tocilizumab in I believe it's the Doberman trial right now. And so there's a lot of excitement for it, but nothing conclusive yet. And the other question it raises is, if instead none of these inflammatory markers are actually the causal driver of pathophysiology or decline of heart failure, they're just markers, what else is the driver? And there's a whole other arm of pathophysiology related to vasodilation that we've been exploring, particularly as it relates to this molecule called DPP3, dipeptyl peptidase 3, which is a molecule released in the state of shock, endothelial dysfunction, and tissue damage. And it seems to be a marker of pathophysiology and mortality in all states of shock. The terminal phase of shock, whether it be septic shock, traumatic shock, your DPP3 goes up, burn shock, your DPP3 levels go up. We now have data we're starting to explore that this is also applicable to cardiogenic shock, and the relation there to pathophysiology is one explanation is it actually degrades angiotensin 2, and that may be another element of how we sort of lose that compensatory vasoconstriction over time. Is this tissue damage? Initial inciting event is heart failure. It's a pump problem, without a doubt. That'd be sacrilegious for me to say that it didn't start there, but it doesn't end there. And then we start to lose that with all these other mechanisms, and then it definitely does get down to the level of perfusion, because we've got this. I love the Reynolds and Hockman model of the death spiral of cardiogenic shock, where you start with malperfusion, and then those mechanisms actually make the perfusion worse over time.
I wonder if I could take a step sideways from the detailed sort of biochemistry and ask about this. I've heard you talk about this loss of compensatory vasoconstriction, and I've heard from other shock physiologies like vasoplegic shocks that late stage cardiogenic shock and late stage hypovolemic shock start to look like septic shocks, like distributive shocks, right?
Yep.
And I wonder if you're learning from each other, from the different expertises that are studying this different problem of shock. You talked about SIRS. Is there a different way we should be thinking about shock? Because the late stage shock, do we kind of all start to look the same as patients?
I think that's a brilliant question. I am operating under that hypothesis. In fact, in order to sometimes sound smart and write grants that sound smart, in particular, to get some of this research funded, I often take the approach that I don't need to reinvent the wheel. I think that when I look at the world of septic shock, I think they might be 10 to 20 years ahead of us. And once you make the connection that cardiogenic shock enters this vasodilatory state, I think maybe there's an overlap, not just with cardiogenic shock and septic shock, but potentially that end stage malperfused state might trigger a common pathway or set of pathways in the body. The body doesn't have to reinvent the wheel. We didn't evolve to have 80 million things doing the same tasks for the body. And so there may be elements of this damage response that is cytokine related or something that ties together the end stage pathophysiology of all types of shock. I actually think that is a very smart way to approach shock, because when we treat shock in silos, right? Sepsis gets antibiotics, cardiogenic shock gets an inotrope or a temporary mechanical support. We lose the fact that if we converge on this common pathophysiology, we might have discovery of mechanisms in one area that are applicable. And we don't have to just live in silos. We might have common treatments for all of this, or common ways to measure and detect failure.
Maybe too, but you can get us back to this sort of general understanding of the endotheliopathy that happens. I mean, some of us who know the channel and our podcast know we have worked in the military side as well, with a strong interest and enduring interest in vasoconstrictive shock from hypovolemia. And so the endotheliopathy that happens here is very interesting. And basically, I've used all of the words I understand about endotheliopathy. I would love to hear more about.
That was actually your word of the day on your calendar this morning when you woke up. Endotheliopathy.
I talked to a trauma doctor about it recently. You get it as a start word, so I've been using it more and more.
Yeah, it sounds good. I'm sold.
So what are the signs of it? I mean, there are a lot of different ways that the endothelium can go wrong, but maybe dig back into the detail of the science and how we can tell. Talk a little bit more about the cytokines. What is it that's producing that problem?
Yeah, was that to Tebow or to me? I wasn't.
No, it's to you. Maybe to you.
Oh, to me. Oh, good, good. You said Tebow in there. I didn't know if he was going to come in with
I'm handing
answers to that.
I know what the science responsibility.
So I'm going to take a slightly clinical approach and relate it to my research, because I have to profess I don't have a PhD in endotheliopathies, right? So, but I have made a couple observations about the response in the setting of late stage cardiogenic shock, and this relates to a paper we published about a year ago in CircHF, where we looked at what I coined, and there was a little bit of back and forth with the editors of whether this is actually something distinct or new, but it was important. I called it the blunted pressure response. So it's very meaningful to me that I can walk into the unit, and the first finding from the paper is that the patients who are on the highest doses of norepinephrine are those that do the worst. They have the worst mortality. And so it's not just that patients vasodilate and then we can correct it, right? There's these paradoxes in medicine. And cardiogenic shock, right? The patients whose kidneys fail, we can replace that with renal replacement therapy, but those are the sickest patients. The patients who vasodilate, I can replace that function, at least at a macro hemodynamic level, with vasopressors, and I can make their blood pressure better. I can even make their SVR better, but those are the sickest patients. Beyond that, I wanted to come up with a metric of, if I give X amount of norepinephrine or its equivalent to a patient, how can I measure the response of that And so we coined this really binary term. I wanted to basically make it a continuous term where I divide SVR by norepinephrine dose. The problem is those on zero, it goes to infinity, and mathematically this all fell apart. So I had to come up with some other way of doing it. And I basically grouped patients to say, did you get enough SVR response to the dose of norepinephrine that you're on? And the sickest of the sick patients are the patients who have started to fail in their vasoconstrictive response to norepinephrine. You can give them as much norepinephrine as you want, and they're actually not augmenting their systemic vascular resistance. This is, to me, a definition. It's not the universal definition, but this is a pathophysiology definition of the same entity we call vasoplegia, which we more commonly apply in the post cardiotomy phase. And I'm not so certain that this is not something that, again, post cardiotomy and in the cardiogenic shock state, which is often, going to cardiac surgery. I think these are common overlapping pathophysiology. And that's the functional marker that I think is the most important. Now, if we have to get a vascular biologist on here to go down to the level of endothelium and tell you what's happening. I mean, I can imagine all these things, but my most precise answer is that the clinical response to pressors starts to fail. And why does that happen? We don't have a good answer for why that happens.
And and are you able to phenotype like patients based on that response? Is that something you mentioned, like you measure SVR right now?
Yeah.
That's with the calf, right? You can get a measurement that way.
Yep.
And is that something you do early in the trajectory of the patient? Like let's say like how many hours after they admitted you would try to get them to give them the dobutamine or vasopressors or whatever, and then make that response. How early do you do this, and how early do you think you can sort of classify that patient based on whether they're a responder or not?
Yeah. Early, I would say I need an answer to that question within 6 hours of managing cardiogenic shock in any patient who is SCI C or greater. I lean heavily. My own practice is to lean heavily on the PA catheter. I would love to have equipoise around it. I find clinically that I find like I'm driving blind without it, and I need to see response. And if you ask me what is the most salient single prognostic factor, it's not any of the measures, the isolated measures themselves. It's the trajectory and response to that initial therapy that I think defines for us, probably is defining for us, this systemic pathophysiology. Because if I can give somebody an inotrope and they do better, 6 hours later their lactate's clearing, great. That's a patient who's going to do pretty well. The patient who comes in and their SVR is 3,000, I'm not that worried about that patient. I love to use nipride and just augment the cardiac output. That's a pure hemodynamic effect. That's not a patient who's entered this systemic pathophysiology phase, which I think accelerates the circulatory collapse. And so that 6 hour marker, which I most often will need a right heart cath to define, I think if I could pick one thing, it's the most telling prognostic factor is your response to initial selection of therapies.
So can you tell us a little bit more about how heart failure related shock behaves differently from the traditional like post-MI shock?
Yeah, absolutely. So this is something that I'm trying to understand. In fact, the first answer to that question would be, I wish we knew a lot more about the differences between heart failure, cardiogenic shock, and AMI shock. And I added in earlier that the third group of the acute de novo cardiogenic shock from heart failure, but not this chronic adaptive phase. So I think one of the main deficiencies in the field right now is going back 20, 25 years. Most of what we know with the highest level of evidence in cardiogenic shock comes from AMI shock. It's the seminal trials that we think of are AMI shock and how to manage it. IBP shock 2, danger shock now, the more recent. And we as a field have extrapolated from that into heart failure shock and said, okay, well, if it didn't work for AMI shock, maybe it doesn't work for heart failure shock. Or if it did work for AMI shock, maybe it will work for heart failure shock. And that's not necessarily true. So one of the key conceptual differences is patients in heart failure cardiogenic shock have lived through this chronic phase, and something has triggered that decline. That something is obviously distinct than an MI. This is not just a cardiac malperfusion. And we've made a couple observations. How those observations relate to clinical practice, we don't yet know. One of the things my group is working on is understanding this mixed shock phenotype and how it differs between AMI and non-AMI shock. And I can say a couple things, and this will be in hopefully a paper to come out soon. But essentially, AMI shock patients vasodilate more than heart failure cardiogenic shock, about 2 times as often. They also die more, but the effect of vasodilation in either group is the same. So once they reach that mixed shock phenotype, it doesn't seem to behave differently. It just actually happens a little bit more in the AMI shock. And if you do a mediation analysis, this can explain about 50% of the increased death in the AMI shock group. Why that's the case, and how do I go from this outpatient patient with heart failure cardiogenic shock who maybe has that low output like we talked about earlier, and now we're weaning off of GDMT because they can't tolerate it. We really want to be able to march out that pathophysiology and say, this is not just a moment in time where shock is defined. This is a chronic progressive phase, and something is changing. I don't think in the heart as much as it's changing in the periphery of these patients that marks their entry into the hospital where we define that cardiogenic shock. So, in years to come, I hope that we have more definitive answers of the differences. I think a major limitation in the field right now is that much of what we're doing is built off of AMI shock, and there are probably some key differences we need to better understand in that heart failure cardiogenic shock population.
Is it correct that in the heart failure population, some of the drugs that you would give them to treat them acutely are basically the same, maybe different doses that they get chronically? Whereas the MI shock patients have never received those medications, those molecules ever in their metabolism. Yeah. Is that correct? Could that also point to
it is true, although I should add with a caveat, drugs like, say, Entresto in the heart failure shock population, there was interest in using this. It tends to vasodilate patients a little bit more than they can tolerate. So we do use RAS inhibitors in the critical care setting. We'll either vasodilate patients with nipride, hydralazine, or something like captopril if we want just a quick on, quick off. Once we add in the total RAS blockade with Entresto and we get this sacubitril component in there, patients may not be ready for that just yet. But they might have been on it before. So absolutely, there are heart failure shock patients who were not tolerating it. We sort of manage the shock and we can get them back on it. But there are also patients that in heart failure cardiogenic shock, the reason we knew they were in shock and maybe even admitted them from clinic to the hospital is, my goodness, over the past 3 months, we've had to back off and off and off these medications. What is changing? Why is it that they can no longer tolerate it? Is it simply the heart pump is getting worse and the ejection fraction cardiac output are declining? And no, I don't think so. I think there's actually changes in the periphery that are happening that are currently underappreciated and not as well recognized.
I think that's really interesting, Tom. So if we had these changes in the periphery that are precipitating this decline outside of the hospital, how do you think we change the systems of care to better support these patients? I mean, these patients we already know are sick, right? Yeah. So this isn't the de novo case. Like we know these people already. Like how do you think we should change the way we manage that patient?
If we wear a research hat, there's 2 steps. The clinical hat's harder because we don't know what to do. The research hat is, number one, better identify these patients, figure out the tools that are going to let us understand this. And it's not necessarily going to be just measuring congestion, with an NT-proBNP or with a CardioMEMS. We need to understand that vasodilatory component or the early stages of malperfusion. So I think 1 is better monitoring strategies, and 2, we then need to, and this is the work of our lab, is to understand the drivers of this so we can go and intervene. Knowing that it's there may or may not help us unless we know what to do about it when we see it. Right. And so both of those have to happen. I think there's a lot of work that needs to happen in the space from a research perspective. From a clinical perspective, that is part of why cardiogenic shock mortality is so high and remains so high, is we just have these knowledge deficits that we have to overcome. And the growing component, if you look at literature out of the CVICU or CCU, it's this heart failure cardiogenic shock that is taking off. AMI is there. We're growing just as the population grows, but heart failure cardiogenic shock, that's the growing population that's becoming the increasingly big global health and United States population burden to our hospitals. And being able to prevent it, an ounce of prevention is worth a pound of cure. We may do a lot better if we can identify it early and do something. What that something is, I don't know yet, but do something and keep working on what that strategy might be.
Well, Tom, this is great. I've got so many questions. I've got this ongoing questions, and I'm glad that we have you as an ongoing collaborator to help me learn selfishly about this and to help steer us in the direction of application for the technologies. I really enjoyed this conversation. It's great to have you on the podcast. Maybe we should do another follow-up where we have some more of these questions addressed too. So
sure.
want to thank you again for being here.
Absolutely.
Thank you.
Thank you. Thanks for having me.